the thing that is absolutely necessary is there should be a lesion or disease of the nervous system for that pain to be labeled as neuropathic pain. It cannot be just dysfunction. Dysfunction was the old definition. The 2011 definition by the neuropathic special interest group holds true even now. So that's absolutely the first thing that needs to be done. We'll fly through these slides. So this is the difference between nociceptive and neuropathic pain. Most people should be knowing it. These are the common conditions that we see neuropathic pain arising in. And these are the terms which are associated with neuropathic pain. This is something which I specifically put in. This is a small tool which is used to actually diagnose neuropathic pain. And there are 10 items on this. At least 4 of them should be scored as positive for us to say that it is neuropathic pain. There are symptoms, there are positive signs that have to be elicited by the physician. And all of those together, put together, if you have 4, then that's neuropathic pain. If you don't have 4, then that's unlikely to be neuropathic pain. It's likely to be something else. I hope you've heard of something called as nociplastic pain. I'll try to describe it in the coming slides. Most of it is that it's not necessarily neuropathic. So coming to treatment, what is absolutely necessary for neuropathic pain? What are the goals? If you can see, the first point is that pain reduction about 50%. That is actually a realistic goal. Realistic goal of, having a goal of 100% pain reduction is not realistic. It doesn't always happen. And the rest of it is very important. Improving of sleep, improving of function, improving of relationships. These all things need to be told to the patient. It needs to be looked at, and every follow-up that needs to be stressed that are you seeing improvement in these things? And if it is not improving, simply relying on drug treatment might not be the right approach. There are few things that we need to know when we are using neuropathic pain medications. All the trials are done on numbers needed to treat. So because of that reason, you can see that the numbers needed, the trial endpoint is generally 30% or 50% pain reduction. It's never more than that. The duration of treatment, most of the trials don't go up to 12 weeks, which is actually required for a drug trial to be deemed successful for neuropathic pain. It's done much lesser than that, so be aware of these kind of things. Like I said, there is many neuropathic pains are actually nociplastic. So what I mean by nociplastic is that the patient has some kind of a pain, and then he keeps getting that pain again and again and again, and they will say that it is diffuse pain, it is radiating, and I feel pins and tingling, numbness, this kind of things. But they're not really. There is no dysfunction of the nervous system. There is no disease of the nervous system. There's no lesion in the nervous system. When you MRI it, when you do a nervous system examination, nothing comes out. It's not really neuropathic. It's nociplastic. It is because the pain signals keep on going into the spinal cord, and the brain becomes plastic. They start the synapses start responding to that, and patients start developing spontaneous pain. That's nociplastic pain. It does not really respond to neuropathic pain medications. You must not use it. And all pain trials have a large placebo effect, so one needs to work with it. Neuropathic pain medications are broken down into first line, second line, third line, and fourth line drugs, so on and so forth. And we will talk a lot on the first line drugs, somewhat on the second line drugs Dr. Preeti has actually spoken on, and some I'll try to just touch upon. So the important first line drugs are the gabapentinoids, gabapentin, pregabalin, tricyclic antidepressants, and the serotonin and norepinephrine reuptake inhibitors, that is the SNRIs. This is an algorithm for using the drugs. So the first line drugs need to be started first. How to make a choice of which first line drugs to start, I will explain in the coming slides. The second line drugs need to be added on if you don't get any response, or you don't get the kind of response that you are looking for in the first line drugs. There are specific circumstances where second line drugs are used. Third line drugs are used depending upon the clinical scenario, the clinician's the experience with that drug, and what kind of pain that you're dealing with. Fourth line and all are basically for specialty pain services, if you have training and you know how to use these kind of things. So this is what that whole algorithm is in very short. Most of the conditions, the gabapentinoids are the first line of drugs to be used. Usually, I tend to use gabapentin in older patients and pregabalin in younger patients. Pregabalin is not very well tolerated by older people. In younger patients, tricyclics can also be one of the first lines. The interview with the patient requires you to ask for other things apart from pain. So one of the things is, how are you functioning? How do you feel? How is your mood? Are you, anxiety, those kind of things. And if the patient scores more on those, they talk more and more that, I'm not able to do this. So it's just simply having a neuropathic pain should not incapacitate the patient. But if it is, the patient is more likely to be anxious, depressed, those kind of things, the SNRIs are a better option to choose in those kind of patients. We use some of the opioids like Dr. Preeti said, but they are used basically for flare-ups or for acute pain management only. Long-term opioids in neuropathic pain is a very, very controversial topic and should be avoided as much as possible. The second is, we don't get those kind of opioids like oxycodone and hydromorphone in India. And so using morphine for long-term pain control is absolutely not the right way to go. Interventions can help in some kind of patients. We should always choose some intervention if it is possible for pain control. Other non-pharmacological treatments like rehab interventions, psychological counseling, those kind of things also tend to work in these kind of patients. They are very, very underutilized by us. And if the patient fails two first-line drugs, then please consider referring these patients to somebody who has more experience in handling these kind of patients. So how do I choose drugs? So gabapentin is chosen as, there are two ways in which you can choose. You can choose 100 milligram TID to start with, or 300 milligram once a week, and then up-regulate the go up the dose as and when to the response that you are looking at. So 50% if the patient improves, or even 30% the patient improves, you can maintain at that dose for at least 12 weeks. So that is till 12 weeks the patient should be having good amount of pain relief. After that you can start. Now this is for pure neuropathic pain. Remember the caveat to this. For pregabalin, the dose is slightly lower. For duloxetine, it's 20 and then goes right up to 60 to 120, venlafaxine and amitriptyline. So these are the first line drugs. Some of the side effects of the first line drugs, these are the things. They're okay. You need to be careful in cardiac patients. You need to be careful in elderly individuals. You need to be careful in patients with hypertension. SNRIs do tend to raise the blood pressure a little bit. So if you are using SNRIs in somebody over 40, please let them know that you need to monitor the blood pressure. If it goes up, then you need to change the drug. Lidocaine patches are used in patients with focal neuropathic pain. Say for example, a post-herpetic neuralgia works very well. It should be used for 12 hours on and 12 hours off. You can use it for about 3 to 4 weeks. What happens if the patient does not respond? So there is something called as a complete non-responder. So you have used, say, the maximum tolerated dose for a patient is 1200 milligram of gabapentin. You have used it for 2 weeks and the patient shows no improvement. What you need to do is you need to switch to another first-line drug. You can either switch from gabapentin to pregabalin straight. The conversion ratio is 1:6. That is 6 times it needs to be reduced for pregabalin. Or you can switch to an SNRI. Okay. The next group is a partial response. Patient gets, say, instead of a 50% pain reduction, gets a 20% pain reduction. You can add another group of drugs. So now what can you add? I'll show in the next slide. And the third is that the patient continues to say that I don't have any response. You have used 2-3 drugs, or it continues to have a partial response. Use something else. Use an intervention. You refer the patient to somebody who has more experience in using these kind of drugs. Use non-pharmacological methods for treating this patient. So this is what has been, what I described in the previous slide. This is what the algorithm for that is. What are the combinations that you can try? Pregabalin or gabapentin can be, a tricyclic agent can be added to this. Capsaicin or lidocaine, like I said, for focal neuropathic pains like for post-herpetic neuralgia. And you can use an opioid like tapentadol or tramadol because they have SNRI and inhibitor kind of effect, and they can be used for flares for limited amount of time. What should not be used is you should not be using SNRIs with tramadol. They cause something called as serotonin syndrome. It is an extremely life-threatening thing which needs to be, which the patient will go into the ICU for management. So please don't use this combination, and don't use pregabalin with duloxetine. That is an SNRI with a gabapentinoid. There is no evidence to say that this combination is superior. It just adds to the cost without any improvement. What are the common mistakes that we made? Generally, we don't talk to the patient. That requires a lot of talking to the patient to make them understand what is a realistic goal of treatment. We use 2 drugs from the same class. Again, that is I've seen people write gabapentin and pregabalin for the same patient. This is not going to work. Okay, we switch too soon. We don't give that 2 weeks of full dose to tell before we make a judgment that this is not working. We don't use combinations correctly. We use opioids with non-exit strategy. If you keep on using opioids, the patient will come back to you and keep on demanding opioids or go to other people who are willing to prescribe opioids. It's a wrong strategy. And we forget the other tools that are at our disposal, interventions, non-pharmacological treatments that also should be added. So I want to finish by just telling that be sure as to that you're dealing with a neuropathic pain only and not with something else. Please use drugs rationally and have a strategy of what you're going to do with patients who don't respond to your first line drugs. Thank you.